Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is the introductory lecture for Parasitology. It's Module 44. We're going to introduce you to parasites and protozoa. We'll also talk about some amoeba, some trichinella, some giardia. We'll go through some fun stuff and be able to make sure you understand it so you can get the questions right on Step 1. Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology Module 44, Parasitology. Parasitology involves the discussion of protozoa, and they have different hosts. They're different than bacteria and fungi in that they will have an intermediate host where you'll develop larval stages. The definitive host, then, is the host for the adult parasite where it reaches sexual maturity. They depend upon vectors, both mechanical and also biological. The mechanical vectors transport the parasite, and there's no development of the parasite in the vector. Some of the stages of the life cycle do occur in biological vectors. Protozoa are unicellular eukaryotes, and therefore they're difficult to treat. They have asexual reproduction mostly, but some undergo meiotic or sexual reproduction with several variations. There are a limited number of protozoal diseases, most common in tropical developing countries or in immigrants or travelers. Some definitions about protozoa. A cyst is an immotile, dormant stage that's ready for harsh conditions, and that's where they can live and be transferred through the environment. The trophozoite is the vegetative state. Protozoa are frequently classified according to their mode of locomotion. Protozoa achieve motility through the use of amoeba, or flagella, or sporozoa. Amoebic protozoa include Entamoeba histolytica, Nalgeria fowleri, and Acanthamoeba species. The flagellate protozoa include Giardia lamblia, and sporozoans include Cryptosporidium parvum and Isospora. Those in the urogenital tract are often flagellate, like Trichomonas vaginalis. Those protozoa that infect the blood and tissues are usually sporozoans, like Plasmodium species, Babesia, and Toxoplasma. There are also flagellates that infect the blood and tissues, including Trypanosoma and Leishmaniasis. Intestinal protozoa have a classification scheme based on amoebas, flagellates, and ciliates. Balantidium coli is the only ciliate to cause human disease, and even then it only does so rarely. Sporozoa are obligate intracellular parasites. The adult forms are non-motile, and they have complex lifestyles. Usually, the definitive host harbors a sexually reproductive stage, and the intermediate host harbors an asexual reproductive stage. This table lists the antiprotozoal drugs, based on which drug and which target they use. So just like with the bacteria, we have sulfonamides, which target the folate pathway, tetracyclines, which target protein synthesis, but we have new diamidines, which bind to DNA and treat pneumocystis and leishmaniasis. We have arsenic antimony compounds, which treat sulfhydryl groups for trypanosomes and for leishmaniasis. The antimalarials are a unique group of medications which target DNA replication, protein synthesis, and reactions with blood. These include chloroquine and primaquine, deoxycycline, armatencenin, and haloflantrine. Balantidium coli is a common cause of dysentery with blood and necrotic tissue. It will not form abscesses, and its diagnosis is based on finding ciliated trophes and cysts in the stool. So if you have a protozoa that has cilia and it's causing disease, it's Balantidium coli. The infection is acquired by ingestion of cysts, which are present in the water, which is frequently, unfortunately, contaminated by pig feces. The cysts transform into ciliated trophes in the body. Amoebic dysentery is caused by Entamoeba histolytica. We get cysts to the human from the water. Trophozoites then go to the colon, and they eat bacteria in our colon. The trophes form cysts that pass in feces, and they're resistant to chlorine, and they spread the disease to other people. The trophes can also invade our intestinal epithelium, causing abdominal pain, blood and mucus in the stool, and causing bloody diarrhea. They can travel to the liver or to the lung and cause abscesses, where they'll frequently have what's called anchovy paste. It's kind of a pustular red material around their abscesses. The diagnosis is based on cysts or trophozoites in the feces, and you can use serology for disseminated disease. You can treat with metronidazole. You can also try iodoquinol, diloxanide furoate. Severe cases are added benefit from antibacterial activity. Entamoeba histolytica has unique microscopic features which are shown here. We have tetranucleated cysts with trophozoites with an ingested red blood cell and chromatid bodies. Question. A 29-year-old male who has recently returned from Guatemala presents with severe acute right upper quadrant abdominal pain. He's had several months of bloody diarrhea. CT scans of the liver demonstrate abscesses. Which of the following organisms is the most likely cause? So we've got somebody who's been in a third world country where they're more likely to get a parasite. They've got right upper quadrant abdominal pain, months of bloody diarrhea, and an abscess in the liver. Your most likely cause is going to be Entamoeba histolytica. Balantidium coli, they're going to mention something about cilia. With Ascaris and Enterobius, those are helminthic infections, and so that's not going to be discussed here. Next question. A psychotic indigent man with a history of multi-substance abuse presents with bloody, persistent diarrhea. Stools are sent for ova and parasites, revealing numerous granular, spherical, thin-walled, tetranucleate cysts measuring 10 to 20 microns in diameter. The most likely pathogen? This again goes back to that picture. If you remember that they have tetranucleate cysts, you can remember if you want 10 to 20 microns in diameter. But you've got somebody with bloody diarrhea, they've got parasites with tetranucleate cysts. That's Entamoeba until proven otherwise. Giardia, we're going to talk about, has a different appearance, and the other two are not as, and Cryptosporidium and Dientomebia also have unique appearances, which is not a tetranucleate cyst. Amoebic meningoencephalitis is an important cause of death with parasites. Acute meningoencephalitis in normal hosts versus chronic granulomatous disease in immunocompromised people. Nalgeria fowleri is a common cause of acute or quick meningoencephalitis, but if you've got acanthamoeba, it's going to be more of a chronic, slower granulomatous disease. It is associated with swimming in freshwater lakes, and what you can do is you get an accident where they have facial trauma, they rupture the cribriform plate, or they get hematogenous spread. If they have Nalgeria, they'll get acute meningoencephalitis, and the CSF exam has only motile amoeba, whereas if it's acanthamoeba, they'll have amoeba and cysts. Acanthamoeba is also associated with corneal infections. These people have a history of contact lens use, and they're cleaning their contacts in non-sterile solution. Next up is Giardia lamblia, or giardiasis. This is where we ingest the cysts from contaminated water. Then we get a binucleate trophozoite with numerous flagella. The trophs attach to our duodenum. It's important to remember that it is the duodenum, but they don't invade. They do interfere with fat absorption, and so patients get greasy, foul-smelling stools. The trophs form cysts, which have 4 nuclei, and these pass in the feces and are resistant to chlorine. The diagnosis is based on fecal exam, which may be negative. You can also do a stool ELISA to detect Giardia antigens. Treatment includes metronidazole for adults or furazolidone for kids. This is a picture of the binucleate kite-shaped trophozoite that you'll frequently see with Giardia. Questions. Following a camping trip, an 18-year-old male presents with foul-smelling, greasy stools, devoid of blood or mucus. His history is remarkable for drinking water from a stream infested with beavers. Microscopic examination of his stool revealed stingray-shaped flagellated trophozoites. The most likely agent? So this diarrheal syndrome is different than that we've talked about with bacteria, with a rice wattle stool, or dysentery with Shigella or Salmonella, with pussy, bloody diarrhea. This is a fat diarrhea because Giardia inhibits fat absorption, and the classic stingray-shaped flagellated trophozoites tells you it's Giardia every time. Drug of choice for the treatment of Giardia-associated diarrhea is metronidazole. Cryptosporidium species are intracellular parasites of the ileal epithelial cells. They come from farm animals, and we can have an infective form, which is the oocysts, which are very small, and they have 4 motile sporozoites. The disease is often asymptomatic, but it can spectrum all the way over to intractable diarrhea, depending on your immune status. You can have voluminous, protracted, watery diarrhea in AIDS, and that makes you think of Cryptosporidium. The diagnosis is based on modified acid-fast stain of stool for oocysts, and you can also direct immunofluorescent testing and biopsy of the small intestine, especially the ileum. You treat with paramomycin and azithromycin for diarrhea, and often it's unsatisfactory. Cryptosporidium is a cause of chronic watery diarrhea in AIDS patients and can be debilitating and lethal. Cryptosporidium must be distinguished from Isospora, and Cryptosporidium have oocysts which are smaller and they have 4 sporocytes, whereas Isospora belli is very large with 1 immature central and large sporozoid, and you treat that with Bactrim. Question. A 24-year-old AIDS patient develops chronic abdominal pain, low-grade fever, diarrhea, and malabsorption. Oocysts with 1 large immature and central sporozoite are demonstrated in the stool. Which of the following organisms is most likely to be the cause of the patient's diarrhea? So this is what we just talked about. It's most likely going to be Isospora belli if they have an oocyst with 1 large immature and central sporozoite. You treat that with metronidazole. Trichomonas vaginalis is the cause of trichomoniasis, and it's a sexually transmitted disease. We get it from urogenital mucosal inflammation, and it causes a malodorous, copious, watery, and frothy discharge. You can also get itching and burning in a strawberry called cervix. You get abnormal vaginal alkalinity with a pH of up to 6. That favors growth, whereas the normal vaginal flora gives you a pH of about 4. The diagnosis is based on history. You've got sexual activity, then you've got the common symptoms, and then you look for motile, pear-shaped flagellate with undulating membranes on the wet mount. It's indistinguishable from commensal trichomonads, and so it's difficult to treat. You do treat it with metronidazole, and it's important that you treat the patient and his or her partners and their partners. Here's a slide of Trichomonas vaginalis, and you can see here we have a motile, pear-shaped flagellate with undulating membranes. Question. A sexually active 28-year-old woman presented with frothy, greenish-yellow, foul-smelling vaginal discharge. A pap smear demonstrates protozoal parasites. These organisms are likely to be. Since there's really only 1 parasitic infection or protozoal infection that causes vaginitis like this, you're going to know that it's Trichomonas vaginalis. If they tell you there's a protozoal on the pap smear, that's your answer every time. Wrapping up Module 44, we introduced you to the world of parasitology. We talked about some anti-parasitic drugs, which have some interesting names. We talked about the different lifestyles and how parasites are classified based on their mode of transportation. We also introduced you to some of the major players, including Giardia lamblia. We talked about Anamoeba histolytica. We talked about Trichomonas vaginalis. Be familiar with the different diseases these cause. Giardia, you remember, has that little kite-shaped form. It can form a watery, also fat-filled stool, so they'll float to the top of the toilet bowl. Trichomonas has a distinctive smell and odor, and also you'll be able to see it on a prep. Be familiar with how we treat these disorders and what complications you can get from infections with them. Up next, we'll go to Module 45, where we'll continue with intestinal, urologic protozoa, and also talk about malaria.